Okay, good afternoon. I suppose I am audible.
Yes, sir, you are.
Okay. So today's topic is life-limiting illnesses in children and how to approach this. Now, that's a really difficult topic to get into, even though it may appear to be very ordinary. It's not so. That is because the the diseases that children suffer from are, though they appear to be diseases are familiar to us, the pattern of suffering in children and similar diseases in adults are quite different. How adults conceive of a disease and how children conceive of a disease are entirely different. And for most of us, it is difficult to actually stand in the shoe of a child and to sort of experience it, these problems. So that is one of the reasons why life-limiting diseases or illnesses in children are very difficult at an emotional level or a practical level to deal with. The second problem with this type of diseases is that we do not have many studies on this. It's very difficult to exactly compare two types of children's diseases, two types of childhood experiences, and then make protocols out of it. Things will be very difficult because for children, how they internalize a disease, how they sort of vocalize difficulties that are associated with the diseases, and how they experience a bleak future that is slowly coming are different. Thirdly, it's also difficult because this idea of life-limiting illness is actually a Western idea. It's not an Indian idea, because in India, in the West, we take a large number of children. They have problems with the life-limiting illnesses. But in India, quite often, life of children are limited even without life-limiting illnesses. Because, for example, even today in India, diarrhea kills a lot of people, a lot of children. So that doesn't happen in the West. So these are unique to Asia and let us say Africa, certain developmentally backward countries, or places where the general average standard of scientific thought among the people are far below what is necessary for a good quality living. For example, in many countries, many underdeveloped countries, there are still people who do not believe in vaccines, for example. There are still people who cannot have access to modern medical services, and instead they will go to a quack. Perhaps it may be surprising to some of you, at least some of you, that in India, about more than 50% of people who 50% of people who practice as doctors, modern medicine doctors, are either +2 or below that level. They have no degree, even in history or music or dance, they have no degree. So most of them are, when I say most, it's a majority. More than 50% is a majority of practitioners in India are undergraduate level educated people who picked up some information about modern medicine and they go on prescribing medications. So this is the reality of what we have in the rural India. So much so that a few years ago, I think all of you will remember Amartya Sen, who was a professor of economics, and he got a Nobel Prize for his social economics or economics and ethics. These ideas got him a Nobel Prize. So he made a comment that perhaps the only way to sort of improve India's health is to train these quacks in the rural areas and give them some sort of scientific training so that they become slightly better in giving better quality services. So such things are still there, because the fact that we have to discuss such things means that our public health needs to be considerably improved. We need more improvement in public health. So that being so, the idea of life-limiting illnesses is different in India and perhaps in the Europe or UK or in the Northern America. So that's how you see it. But the idea, the moment you say life-limiting illnesses, it brings to our mind a set of diseases which, in the natural course, would limit a person's life. And in our case, in our situation discussion today, that being the children. So that's how we look at life-limiting diseases. So that's why I'll tell you for some of the problems of life-limiting illnesses. I shall share the screen now, and then let us see. I hope you are seeing the screen.
Yes, sir. But
Okay.
can you enlarge it, sir, to slideshows?
Is it okay?
Yes, sir. Now it's clear, sir.
Yeah. Now this will be the sort of agenda that I will try to go through in the time that we have. Now, what are the needs that we have? One is the understanding of what this is, what we are dealing with. Now, when you say life limiting illnesses, it automatically means that the life expectancy of a child with a particular diagnosis will be cut short, will be much lower than the naturally expected life expectancy that a community will have, community of children will have. So in many situations, life-limiting illnesses of children slowly will get reported in the ICUs, or the pediatric ICUs, or PQs as people call it these days. So we find that if you take statistics of all the PICUs or PQs in the developed countries, we find that the overall mortality is slowly decreasing, even though the overall admissions are slowly increasing. So that is the conflict there. So you find that more and more children get admitted, and less and less children die in the PQ. So what happens to those people who, of course, children dying in the PQ is a very sad thing to have. But then, if you think of children who survive the PQ, they still have some more days to live, or some more years to live. And this part also is slowly improving, because when children survive one of the ICU episodes, he has a better chance of surviving for one more year. And perhaps during that 1 year, the child might still come back to the ICU. Now, we have a problem here. The problem here is that the personal experience of a PQ is not very entertaining. It's not a very nice experience. So even for the ICU is not very good. Even adults have problems while simply staying in the ICU, even though they survive the ICU. For example, myocardial infarction. Suppose I have a myocardial infarction, I'm in the ICU for 5 days, and then when I come out of the ICU, I'm a different person actually, because I go through certain types of deprivations in the ICU. So ICU is not a very pleasant experience. And for a child, it is more so, because the child is separated from his ambience, the child is separated from the parents and his social milieu, and the child is also separated from the playfulness that childhood is associated with. So therefore, the more number of times a child has to be in the PICU, it actually affects the quality of life of the child. Not only the child, it also affects the quality of life of the childhood itself. So childhood itself will come down, because childhood is a very vital thing. A child will have the childhood only during the childhood, because once the child becomes an adult, you cannot go back to the childhood days. You cannot reimagine, or maybe you cannot play act your 13 years or 14-year old life. So that is over. So you should have the thrill of the teenage, or the thrill of the pre-10 years at that time only, because when that is over, that is over. It's over forever. So that's a problem with this issue. And there have been studies in the PICU, because many people have studied PICU experiences quite nicely. Of course, once again, these are all studies from the West, where things are much better organized, and there are protocols they have developed protocols to understand how you will grade certain things. Now, children with life-limiting conditions accounted for the majority of admissions in the PICU in the West. But that is not so in India. In India, still trauma will be one of the factors. Shock and infections, which are preventable. Encephalitis. Many of these diseases are preventable diseases in India. They come into the PICU. I do not know whether the PICU statistics in India would be predominantly life-limiting diseases, but in the West it is so. And for those children who come into the PICU, the chance of dying is very, very high, because they are 75% more likely to die than those outside, those without a life-limiting disease. So a life-limiting disease is basically a major killer for children. And but if a child survives the PICU experience, the chances that the child will survive for one more year is very, very high. So there is almost a 93% survival at 1 year for children with life-limiting conditions. That's a very good thing. That means a child who has gone into the ICU will come out of the ICU, will survive for several years, because 93% will survive for 1 year, means maybe 70% will survive for 2 years or 3 years. Therefore, the survival of children is slowly increasing. So this is a good sign. So that a child can go on living and have a reasonably good quality of life. Now, along with the so-called LLC, or life-limiting conditions, you also have another expression called the CCC. These are complex chronic conditions. Like, let us say, like cerebral palsy is a complex chronic condition, which are not by itself life-limiting, but it limits life in various other ways, because malnutrition can happen, repeated infections can happen, or an aspiration can occur. So these are all other issues which are associated with complex chronic conditions. Or, for example, you can also think of achondroplasia. It's a complex chronic condition. It does not affect life, but it affects certain types of mobility. So all these things can be also considered as a set of diseases that are associated with children. These conditions also get occasional PICU admissions. So this will be the general trend of what we are dealing with. So when we think of intervention, we are actually thinking of these situations. Therefore, in other words, I will now say, I will just recapitulate this and say that when you have life-limiting illnesses, you can divide that into two. One, a set of diseases which are simply CCC, is complex chronic conditions, which is a sizable number, plus other life-limiting illnesses which occasionally require a PICU admission, which can become very acute and can lead to an emergency situation. You need emergency admissions, you need PICU admissions and care, and some children might die, and it goes on like that. There's many people might come out of the ICU and live a life of varying type of disability. So any child who surveys the PICU may not be completely normal. They have a primary diagnosis plus some impact to the PICU, which adds to the overall disability experience. This is what we are dealing with. This is how we look at it. Now, there are different ways you can look at life-limiting illnesses. The first track would be that life-threatening conditions for which a curative treatment may be there, but quite often they fail. So that in reality cut down the life expectancy of a child. For example, examples are cancer, organ failure, renal function problem, liver function problem, or a cardiac condition. These are conditions which are really life-threatening, life-limiting illnesses. Technically speaking, there could be some sort of a cure, but you always describe a cure in such conditions in terms of survival rate, so that there are always some children who do not survive, and then you lose those children. So this is the first track of children who have LLI, life-limiting diseases. Now, if you look at the track 2, like another set of diseases, these are conditions where premature death is inevitable. They die during childhood or soon after childhood. Like, for example, cystic fibrosis, Duchenne's muscular dystrophy, things like that, where death is imminent. For example, spinal muscular atrophy. These are all diseases, or some of the types of spinal muscular atrophy. These are diseases where invariably childhood the life would end. Life naturally would end. And we can perhaps only support the child during the period where the child is alive. In track 3, you can think of conditions which are progressive conditions without any cure options. Like, for example, some neurodegenerative diseases. All the neurodegenerative diseases together are called Batten diseases, and mucopolysaccharidosis, which are also necessarily fatal diseases. You don't survive the childhood days. So these are some of the track 3. And in track 4, you have irreversible but non-progressive conditions. They are off the lot. They are the better track conditions that they of course give you severe disability, leading to major morbidity, but not mortality. Mortality comes only because the morbidity accumulates and then it causes morbidity. Like, for example, cerebral palsy. Certain types of cerebral palsy you would have all seen, because they have failure to thrive, because they don't eat well. So they don't take the milk, or they don't drink, or they don't eat well, so that they are always underage, stunted growth, and then they have repeated respiratory infections. They have aspirations, so on and so forth. So that finally, many children might die during their teenagers, or maybe by 18 they die. That is why you find a lot of cerebral palsy children during childhood, but you don't find that many cerebral palsy people as adults. If you look at any OP, all people with cerebral palsy would be loaded in the pediatrics OP. But if you go to the adult OPD in medicine or ENT or dermatology, you don't get cerebral palsy people, because many of them have life-limiting illnesses also, because they are, of course, it is true that cerebral palsy is a static disease. It is non-progressive, and technically speaking, they can go on living forever throughout their have a normal life expectancy. But it doesn't happen to many people, because they have repeated infections, and repeated infections will cause malnutrition, and malnutrition can cause other its own problems. They can aspirate, they can have pneumonia, and so on and so forth. So these things happen. Similarly, some of the brain injury, traumatic brain injury or spinal cord injury, also technically they can go on living for a long time. But if you look at children with having a brain tumor or a traumatic brain injury or a spinal cord injury, you find that eventually they succumb, because at some point of time the care comes down, the the medical attention comes down, or the access to medical care becomes difficult, and it goes like that. So in short, I have given you 4 tracks of diseases. You will find that each of the 4 track has its own pattern of progress. They're also not uniform. They have its own. We'll just run through them once again. Track 1 will be life-threatening conditions where curative treatment may be there, but quite often fails. So cancer and cardiac failure or kidney and liver failure are typical examples of such diseases. In track 2, we have premature death is inevitable. We can only look at what is happening. A typical example will be Duchenne's muscular dystrophy, where the survival is poor. But however, having said that, I would also say that in the Western countries, Duchenne muscular dystrophy people are actually surviving some more, because in India, if you see many DMD children finding it difficult to survive the 18th year or 16th year, you will find that many children in the West go into the adult ages, like they cross 20th year. Maybe they become 21 or 20 years, 21 years. In the rare case, they might even reach this 22nd year. And the chances are that in the next 10 years, some of them will reach 30 years, because technology is coming in. So because they die because of the respiratory problem, you can always support it by technology. Digital technology can support the respiratory muscles, and if that happens, some of them will, and that will create another set of issues for physiotherapy and rehabilitation. Why? Because Duchenne's dystrophy, Duchenne's child is basically mentally normal, spiritually normal, emotionally normal. They're all extremely normal. And so therefore what happens is, past their adolescent period, they have the sexual maturity coming in. They need a sort of pair bonding, and development of sexuality, and all this will cause a little bit of problem for managing at the individual level, or even within the families. Things are a little difficult. And in the West, they are actually in reality very seriously thinking of how people with Duchenne's muscular dystrophy or other diseases in the track 2 illnesses, where they are mentally normal, can be helped to find pair bonding and things like that before they die. So these are other issues which will come in with additional a few years of life expectancy. So that's another thing. So in track 3, I'm just recapitulating the whole thing. These are progressive conditions without any cure. So you can think of all the diseases where there is no cure, and yeah. And now the track 4 are conditions which are static, like brain injury or spinal cord injury, or people with a multiple disability or severe cerebral palsy. They are susceptible to repeated diseases because of the very nature of the disability itself. Now, the problems that you face when you actually deal with children with life-limiting illnesses are not simply with children. It also are related to parents. It's quite often parents find it very, very difficult to understand the life-limiting diseases of their children. It will apply to all of us, any of us. So it's not as though parents are not educated enough. It's very difficult to comprehend how a child has my child was born with increasing disability. Now, one of the important point of departure in the life of a parent is the time of diagnosis. The moment the child is diagnosed with a life-limiting illness, that's a huge shock that will happen to the parents, their family, even the sick child's siblings who are there. Child will have an elder brother or younger brother or sister. So all these people will have different types of shock. And we, after COVID, now speak of the new normal. And in every family, new normal, COVID-related new normal happens in the society. So it's very difficult for us to to sort of manage that. Whereas in the question of these people, children with life-limiting illnesses, this new normal happens within the family, and it is very difficult for parents to go out when they meet other people to discuss this, because others wouldn't understand. Others do not understand how serious this so-called new normal behavior is, and how the new normal manifests with the life of the parents. So therefore, parents have difficulties in discussing their emotions. They have difficulties in forming relationship outside. So imagine that one of your friends has a cerebral palsy child who is severely disabled. Then it becomes very difficult for them to bring the child into the drawing room when there are visitors. Some people do it, some people do not. Some people will push the child to a room and then keep the child secure, and it will affect their sort of going out for a party or going out for socializing, things like that. So these are all major issues that develops within the family, and quite often even between the people in the family, there are problems. And in India, that is very common. Having a child with a disability, having a child with especially a serious disease, is a cause for divorce. Quite often, the family breaks down. The husband, if the husband is employed and well endowed, he will simply throw the family and go away. So putting the entire stress on the mother. So that's a very tragic thing that happens in India. We are not addressing those things. And these are things which we need to at least think of and discuss so that these can be addressed. If not today, at another date, we can address them. The other issue is that traditionally in India, the caretaker is supposedly the mother. So if the mother also has a child with a life-limiting disease, it becomes the mother's additional burden to carry this child always, go around with this child, look after the child, do the basic things, ideal activity for the child, take care. All these things have to be done, and then she will have to do whatever is customarily expected of her in the household. So she becomes a spent force after some time. So being tired of caregiving is a major thing that one of the parents, especially the female parent, suffers from when you have a child with a limiting disease. The third one is that life-changing nature of the child's diagnosis. It affects all aspects of their life, from everyday life, relationships, spirituality, value systems, and ambitions. Quite often they lose their employment, or they do not accept a transfer or a promotion. All these things will happen. So it changes the whole system. It destabilizes families. So that's a very important thing. So when you actually think of managing these people, we have to think hard at the way parents are actually negotiating their lives with them, and you have to support the parents, number one, because parents have to behave like parents, and they have to be supported at every point. Otherwise, what will happen is they become tired and burned out. So burnout is something that you have to prevent. So when you think of physiotherapy, not only the child, also the parents. Okay. So how does this impact the healthcare professionals? So we have to be accommodative to parents' concern at all times. Parents may shout at us. Parents may be indignant about some of the conditions, but they are actually dealing with a very, very bad situation. So we need to share their concerns, and you go on telling them how the care and the role of parents can evolve at different settings. And we need more research, especially in India, how relationships can be fostered, or how maybe rehabilitation or palliation can actually support the family is a matter to be researched in. So we do not have enough amount of good quality papers from India. Good quality experiences are not there. Okay. So this is one area which are. Yeah. So now the other issue is pain. One of the very important area of, of course, you know all these things. So I will not spend time on this. Now I will try to spend a little time on the the real problem of managing life-limiting disease. It is said that when you discuss physiotherapy or rehabilitation in, let us say, in hemiplegia or a paraplegia, you always say you put a target or set a goal and then do something to achieve that goal. So this is all it's a customarily expected thing to do. But in diseases of the children where the life limiting diseases are there, it's practically very difficult to set a goal, because once you set a goal and try to achieve that goal, the goal is already lost. Child would not be able to achieve it because this is also is progressing. So it is said that many a time when you are dealing with children with life limiting diseases, we are also competing against a moving target as a goal. The target itself is moving. So what was a target last month is no longer a target today. So that's a major issue that we have. So this is something which you should know. The target goes on moving, target goes on changing, and this is something which you have to understand. I'll share with you one or two videos at the end, so that this idea can be there, can be understood better. Take for example a child with cancer. So if a child with cancer has multiple issues. You have a basic functional level as on today. Then 1 month later, the cancer would have increased or would have gone into remission. Or the child may be in chemotherapy and the adverse effects of chemotherapy would have come. Or some of the adverse effects would have regressed. Or some of the psychological impacts would have happened, that would have made a little regression. So all these are dynamic features in a child. For example, the adverse effects, the pattern of adverse effects of chemotherapy or even drug or cancer itself is a bidirectional thing. The cancer itself is bidirectional. It may increase, it may metastasize, or it may regress because of treatment. So everything is bidirectional. It goes on moving, and there are multiple variables going on moving. The cancer itself is moving, the adverse effects are moving, the emotional and spiritual are moving, the child's experience of the parent and some environment, they are also moving. So multiple variables go on happening simultaneously in a child's life. So this is a very particularly important thing to remember when you actually plan rehabilitation or physiotherapy in such situations, because you should know how to validate or how to understand the concept of moving targets. So when the targets are moving, you cannot be very sure about what we can do. Now, there are many types of requirement for children. We discussed the requirement of the parents. We'll come back to the children as such. I said the targets are always moving. They're all in a flux always. Now, the needs of a child with life-limiting illness can be considered under various heads. One of the simple things would be biological needs. They require certain biological functions, like you have to institute a therapy program with minimal side effects. So you cannot give simply, let us say, gait training. It has no value, because unless the gait training is given with minimal side effects, it has no value. And with every intervention, there should be parallel intervention to improve comfort. So for an ordinary child, gait training means walking. For a child with renal dystrophy or a cystic fibrosis, walking is not easy. Walking has to be given with a set of playfulness. So that's very important, because side effects have to be managed. Side effects can be simply sweating, vasovagal syncope, anxiety, or a blank face, or inability to participate. All these are side effects. They are all adverse effects. All these are, it's not simply biological side effects that you actually like pain or nausea. No, other things are also side effects. So you have to do a therapy program with minimal side effects, and there should be intervention to improve comfort. So a child should be comfortable at all times. And our intervention may be successful, not at all times, need not be successful at all times. It should be successful at most of the times is possible, but comfort should be at all times. And similarly, none of our intervention should create a chance of infection. And it should also support the whatever care is ongoing, whether it is a hospital-based care or a outside hospital nursing care or a parental care. All these care should be matched with the type of intervention we give. This is a very important point, because all children with such severe disability and life-limiting diseases will require multiple sets of intervention. Some of the intervention we may find, we might feel that they're not very very important, but they're all important for the child. It could be parental intervention, it could be from the ASHA worker or the nursery teacher. They will be doing some intervention. Similarly, the therapist or the rehab team may be doing something. The palliative care team will be doing something. So all these are little by little, they're all interventions. All interventions should be taken very seriously, and you should make sure that there are no conflicts among these different tracks of intervention. That's very important for looking after the biological needs of children. The second aspect of need is the psychological aspects of need. And there, once again, children and parents require information. Child also needs to be told, motivated. Even a 5-year-old child can understand certain things. Because if you do not talk to him or her, the child will be anxious. Child will be non-cooperative. Child will be really scared of, especially strangers. They are scared. They are not very comfortable with strangers. So, child would a normal child would want to get involved with people on their terms. Children tend to accept adults. No problem about that. Of course, they tend to accept their parents best, but they also do accept other adults. But they accept adults on their terms. They progress slowly, and then they get to know the adults, and then they give faith. So before they give faith, there's a time when this has to slowly evolve. And during that time, you have to motivate them, and you have to apply tools to overcome their anxiety, or the children or the parents, and elicit parental involvement, and of course give a set of education for children and their families. So this is a psychological, it's a professional sort of thing, and I think we are quite capable of thinking of that and doing it. Then comes two other areas of intervention. They are called social and spiritual areas. Children need a society. All children need a good quality society, and one of the important social function of a child is playing. So playing is a form of training for adult life. Playing is also a form of education, and the child requires a school ambience. Child requires a group of peers with whom the children can negotiate and feel comfortable with. And of course, they need social support. So these are one by one, you have to tackle them, especially in cases of children with life-limiting diseases. Make sure that the child has some opportunity to play, some opportunity to get involved with other school children, or whatever, in whatever limited manner. Maybe may not be 5 hours per day, maybe even 45 minutes or 1 hour per day. It's good enough. It's better than not having it. Similarly, socializing is extremely important. So make sure that the children are able to socialize. Similarly, the children do have a spiritual track also. They require spiritual. They have spiritual needs. Though it doesn't mean that the children should be a God believer or not a God believer, religious. No, nothing like that. See, they require some sort of a support, which are extra emotional support. So that comes from their how the parents think of life. So they have to have some sort of a spiritual guidance. So the spiritual guidance can be absolutely neutral, or it can also be related to how their parents think about that. And children who are preparing for death should be made as pleasant as possible so that they can die with dignity. So death with dignity applies to children in the same manner in which it applies to adults. Now, uh, when I say this, there are certain special situations where you should also know that the greatest the tragedy that you will actually see is in Duchenne's muscular dystrophy, because the child's brain is normal. And Duchenne's muscular dystrophy is a inherited condition. So if a person has two boys, both of them might have Duchenne's muscular dystrophy. And slowly, the second child, the younger child, slowly learns that he is actually going in the same direction as the elder child. So the elder child is able to walk, the younger child is running. And after some time, the elder child is unable to walk, the younger child is just able to walk. And after some time, the elder child goes in the wheelchair, and the younger child is stumbling. And then he realizes that after some time, I will be in the wheelchair. And then the elder child has to go to hospital every now and then, be on an oxygen, and then comes back. The younger child now realizes that I will also be in the oxygen. So looking after the second child is extremely important. So that's one of the things that you should always remember, because the younger child understands. Even though the parents say nothing will happen to you, we are here to look after. No, the child knows that, yeah, the older child is getting slowly sicker and sicker, and I am going in the same pattern. Whatever you say, he realizes this. And then, so such diseases, especially in inherited diseases, if there's a second child, manage the second child. Think of the second child, put extra effort to make sure that that second child's social and spiritual requirements are absolutely met, because you don't want sadness to affect a child in the when the child has to live with dignity. And of course, yeah. So that these are some of the things which I have to say. I'll now share with you a video, two videos, because I'll that will show you how, that will simply show you how to. Can you see this?
Yes, sir. We can see the. So.
This is a child with hydrocephalus. Let's see how. Yeah. So now you must have seen the child taking lot of efforts to just watch once again. Now she also understands. It's not. She also understands the need to stand. She loves to stand actually. So the moment you do this in a clinic or a hospital, a lot of people will come and start supporting the child. And look at the amount of happiness she has when she's able to stand. So this is something which you have to match these expectations. You have to see that the child is actually, when the child stands up, she has a sort of accomplishment. So the happiness of accomplishment is one thing that you have to match with the effort that she has to take. So whether to make her stand or not is not what the parents would want or not. You should not make a decision on that point. You have to make a decision on the amount of effort that the child has to take, and amount of happiness the child will have. This child particularly likes to stand, and therefore we have to make her stand, at least to gain the experience of standing. But then the standing may not be much. She may not be able to walk. She may be able to walk, may not be able to walk. That's another issue. But the basic idea is that you have to match these things. So now I'll show you one more I don't know. I think something has happened. Can you see this?
No, sir, we cannot see your screen, sir. The screen is not shared, sir.
I think, have I gone out of the meeting?
No, sir, actually we can see you, sir, but the screen is not visible for us, sir. Yes, sir, as of now we can see you.
Okay, so we'll take from the beginning. Now, this is a child with Duchenne's muscular dystrophy. You can see that he has calf hypertrophy. He has got a spinal deformity. He has got an abdominal problem. Look at the effort with which the child is walking. The child has a broad-based gait. All these things you can see. Just watch for some time. So let's just look at the face of the child also, because the child is saying he cannot stand up, but then the parents are actually asking him to do that. Yeah, see, it actually tells you some of the conflicts that you can actually see in the house, because the parents want something more to be done. The child is unable to do that because there's a mismatch between the expectation of the parent. Can you hear me?
Yes, sir, yes, sir.
Yeah, expectation of the parent and what the child can actually perform. The child is really, it's very difficult for the child to sit down and get up. Even sitting down itself, child will lose balance. So look at the way he is spreading his legs to gain some balance, and he's not actually sitting down, it's actually sinking into the floor, and he cannot get up. So these are major issues. Then there will be some mismatch between the parents' goals and the child's goal and our goal. And parents would want the child to sit down and come up, because it's very important for it will aid the toilet function, caregiving, etc., etc. But then we need to have more practical way of looking at things, and then settle this conflict between the parent and the child, because after all, the child is slowly becoming weaker and weaker. He's able to precariously walk on flat surfaces, but he is not a community ambulator. The moment he walks in his village, he will fall down, because any irregular terrain he will not be able to manage. So we need to have the expectations addressed very, very pragmatically. So that's why and you also look at the face of the child. This child has a very blank face, unlike the other girl who had a very pleasant face in spite of her major disability. She had extremely bad hydrocephalus, with considerable thinning of the brain, but she is still happy. Whereas this boy is mentally okay, but then this boy is very unhappy with the whole situation. So people are actually forcing him to do that. So that is where you need to strike balances. Okay, that's all that I would speak to you now. Maybe we can stop here. If there are questions, I can take. Thank you.
Thank you, sir. Thank you once again for this wonderful session and related to this life-limiting illness among children. So it's time for the doubts and suggestions regarding this session. So it's over to our participants. If anyone of you have any doubts or suggestions, you can unmute yourself and speak up, or else we can move to the case presentation. If you don't have any questions, we can move on to case presentation. Shall we move on to case presentation, sir?
Okay.
So today a case will be presented by Smisha Parikar, and I request Smisha Parikar to start the case presentation. Over to you, Smisha.
Thank you, sir. Thank you. My name is Smisha Parikar, and I'm a physiotherapist in an NGO called Novi Survat in Goa. So there's a question in the chat box. Would you like to answer that first, or should I continue?
You can continue, Smisha. We can discuss it after the case presentation.
Okay, sir. My case, the child is 11 years, male, and he is diagnosed with spastic quadriplegia, CP, with the right hip dislocation. Can I have the next slide? Presenting complaints as told by the mother, child is unable to hold his head, he's not able to roll, and neither is able to come to sit. Next, please. History of illness. In prenatal history, mother has no history of diabetes mellitus or hypertension. In postnatal history, child's birth weight was 3.4 kgs and birth cry was absent. Child had an episode of seizures while shifting when he was being shifted to another hospital, and there was no history of jaundice or no history of hypoglycemia. History of present illness. Mother suddenly went into labor during her 8th month of pregnancy, and she was then taken to a private hospital where a C-section was done. Child did not cry after birth. Child was diagnosed with HIE stage 3, and child was kept in incubator for 1 month. Child was fed through Ryle's tube, and there was no history of jaundice. Child was advised for physiotherapy at 2 months of age. Milestones were not achieved. And family background, there are 4 members in the family. Child has 1 younger sibling who is 6 years of age. Family history is not significant, nothing significant. On examination, on observation, posture, he has opisthotonous posture. Tone is hypertonia, bilateral upper limbs, and rigid extension in bilateral lower limbs. Range of motion is restricted in bilateral upper limbs and lower limbs. Reflexes, upper limb exaggerated and lower limb also exaggerated, and ankle clone is present. Gross motor, child is always in supine position. Child holds his head partially when made to sit passively. Fine motor, child cannot grasp any objects. His head circumference is 40 centimeters, chest circumference 52 centimeters, height is 97 centimeters, and he weighs 10 kgs. His visual, child is unable to track objects. Auditory, child responds to auditory stimuli by turning his head. Speech, the child is not able to speak, and he's dependent on his mother for all the ADLs. Investigation, EEG was done at 5 months of age and recordings were within normal limits. MRI of brain was done in the year 2010. A plain MRI of brain was performed using T1, T2 weighted FLAIR PD sequences in multiple planes, and findings were suggestive of multicystic encephalomalacia. X-ray of the right hip has been done. X-ray of the right hip has been done, and it is suggestive of right hip dislocation. For treatment, we give him MFR for all 4 limbs, side-lying head control facilitation, sitting with support, prone on elbows with weight bearing, rolling facilitation on the mat, and positioning has been advised and taught to the mother to perform at home as home program exercises. Besides, we've been provided him with a CP chair. We provided the child with a CP chair. Psychosocial aspects. When mother learned about the child's diagnosis, she was totally shattered, and she was not ready to accept that the child is having such an issue, and she had no family support. Now she's actually accepted it. There was no family support. However, her employer was very supportive. Her neighbors were very helpful. Her younger daughter was told that her brother will not get better and eventually die, after which she cried a lot, and the mother had a tough time to console her. Now they are emotionally stable and keep self happy. Medications, drug history, the child has been given Calcimax P, Volfor XT, Volprol syrup, Leofen, Pacitane, and Topirol 25. Main concerns: physical, the child is totally dependent for ADLs. He's dependent on the mother. Psychological, mother was mentally broken, worried, and she wondered when the child will be all right. But eventually she realized he cannot be cured but managed through physiotherapy. And younger sibling is under mental pressure. Socioeconomic, they have a low socioeconomic status. Husband and wife both are on daily wages, and financially they are not very secured. Husband is also alcoholic, and employer and native people were very supportive. Spiritually, she always had that, she had the feeling, what sin have I done? Why with me? It's always. So mother was losing faith in God in the first phase of his diagnosis, but eventually she strengthened her mind and faith to take care of this child, and she said it was God's wish. So God has a plan for her. So she has now accepted it. Next slide, please. So summary: it's an 11-year-old child with spastic quadriplegic CP, not able to hold head, unable to sit independently, dependent for ADL on mother. We have provided him with a CP chair, and we are also providing them with ration. Monthly, we send them ration. Discussion points: how do we improve the quality of life for this child? And also, how can we help the younger sibling to cope with the fear of losing her brother? Thank you.
Thank you, Smisha. Thank you for that.
Thank you, sir.
Wonderful presentation. And it's time for the discussion time. I request all our participants to actively participate in the discussion of this case. First, participants from side. We can get some suggestions and remedies for this case and discussion points. Then we can move on to Nandakumar sir. So these two are the main discussion points of this quadriplegic CP child. How do we improve the QLF for this child, and how can we help the younger sibling to cope with the fear of losing her brother? Yes, actually, Dr. Gargi has mentioned in chat box that motorized wheelchair can help to ambulate or ambulate the patient with proper neck support.
Hello.
Yes, Misha, go on.
Yeah, so they cannot afford a motorized wheelchair, sir.
Or do they have
some NGO connections? Can we do that?
Yeah, actually, the mother she finds it difficult because where they're staying, the house is very small, so they cannot accommodate even a wheelchair or whatever. So we provide them when we are transporting the child from his place, or we are seeing the child. We always provide him with a wheelchair, and we transport him. That's how it is being done.
Okay.
So any other suggestions or comments on that? But I think there will be some government policies or some funds related for this type of children with disability, or for even I don't know in your place, but in Kerala and all, for there will be some funds and this for even for some CP childs and all. Have you ever tried on that side? Like,
Yes, sir, they do have here disability certificates and all. They make wherein they provide them with some income, monthly income. I think about 1,000 or 2,000 something per month, sir. And we have helped him with we have given him CP chair and all, because most of the time the child is at home, so she doesn't need to take him anywhere, the mother. And she's also working. She's working in she does all the household work for many people. So she leaves the child at home, and she makes him, when she feeds him and all, she makes him sit in the CP chair that we have given him, and that's how they take care of the child. I mean, that's how it is.
okay, Shan, what about his sister, or what is her age? The sibling?
She's 6 years, sir.
6 years.
6. Yeah. She is too small, but she also goes to school, and some her employer actually is helping her with the fees and all for the child, for her daughter actually.
Okay, Smishan, thank you. Anyway, our participants can comment on chat box, or they can unmute. Now we can move on to Nandakumar sir. Over to you, sir.
Yeah, your discussion points are actually very good. How do you improve the quality of life of the child? How can you help the younger sibling? Okay. Now, the quality of life of the child, yeah, already things are very precarious by the details that you have given. The child is 11 years now, and the height of the child is only 97 centimeters. So actually, it's a stunted growth, is not. There's a growth stunting already.
Yes, sir.
It's a small child for the age.
Yes,
But
sir.
11 years, you need to be taller, is not bigger.
Yes, sir.
So this is what the child has been caught up with malnutrition and low food intake, etc., etc. That is natural. You can't help it. This is
Yes.
how all children with extreme disabilities would behave. Now, some of the things that we can immediately do is to give all the vaccinations for the child. For example, for repeated respiratory infection can be taken care of by annual vaccination. So those things can be considered. Now the other thing is, it is the looking after the mother that matters. So this is an opportunity for the mother and some of the rehabilitation people, professionals, and the mother and father can sit. Maybe if you can get a breakthrough, you can convince the father that alcohol is not a solution for this, and this is something that you need to work on. So if the father can cut down on his alcohol, that will be more money for the family. And if you can come out of the alcohol habit, that means the family will have a strong support, and that will help the younger child also. Now the situation is quite appropriate today, because in your previous slide, you said the mother considers that the God has a plan for her also. So she immediately was confused, and then she now has accepted the situation. She thinks she has brought back her faith in God, and she thinks she's playing by a God's plan. So if there is a divine plan that she believes in, and if the people can bring the husband into a proper family man, that's a huge thing. So these are the things which will improve the quality of life of the child. The child itself would be in one of the tracks that we discussed. The child will naturally have a lower life expectancy because the child is already malnutritioned. So it is the malnutrition that will affect the child in the long run. So it's very unlikely that the child will have already 11 years old. The chance of ambulation or improvement is practically very little, or you cannot expect anything. If something comes, yeah, that's a bonus. That's all. So I would say that looking after the child like this is the most important thing. And while the mother is looking after the child, you said the mother is the caregiver. The mother is looking at after the child. You need to address the mother because mother will be burned out. See, looking after 11-year-old child is not a small thing. It takes tremendous amount of physical effort to take the child from the wheelchair or bed, take the child into the toilet, clean the child up and bring the child back, dress the child, put it on table, then go and do all her household activities, and then go and do her jobs elsewhere. So that's a tremendous amount of physical effort. So you need to have good quality support for her and find out whatever you can do for the mother. You do that. That will be a great thing that you can do. And you can also think of some ergonomic support for the mother so that she will be able to look after herself. Yeah. One comment has come through some play or story. We can explain the younger sibling. Yeah, Now that's another thing. That's a very interesting intervention. The younger child also can be encouraged to participate in the care. So maybe support the mother, do small things. That way, the younger child will slowly cope with the fear of losing the brother. Because at 6 years, by around 5 years, children understand what death means. So they have a vague sense of death by the time a child is 5 years. Even though the child doesn't understand exactly what death means, we also do not understand what death means for that matter. But then after 5 years, child can be slowly brought into the care system so that the child does not have a shock when her brother dies, and she'll be perhaps sensitive to the reality of the situation. The mother would be already sensitive to the reality of the situation, and those are the things that you can do. The other thing that I would say, that the technology, applying technology, of course, is a good, interesting thing, but technology should match the ability of the child, and they're able to how much you can afford, because having a motorized wheelchair in a place where it is not will not be functional doesn't help. On the other hand, if the child can be brought out, or the child can stand or walk, or child can go to school, then it's a different matter. You can always think of a sort of a motorized wheelchair, but that doesn't make sense at the present moment. This child doesn't do that. So at present, this child will have to be supported until the child lives without compromising the existing care. You need to give good quality food. Nutrition perhaps is another thing that you can think of. And in Indian rural areas, many a time mothers will give their children mostly starch because they do not understand the requirement, the need for proteins. So if you can increase the protein in food and reduce the starch, then the number of infections might also come down, and the child will have a better quality of life. So because if the child has frequent infection, it is an added strain for the mother. So finally, whatever happens, it is the mother who has to bear the strain. The father will escape into his bout of alcohol, and yeah. So that's the traditional family situation that you have in India. So these are the things which I would think of. Yeah, the younger child has to be managed. I think the mother has to be managed. Have one or two group meetings with the family, so that you can bring the father down, and maybe you can elicit a sort of a promise that you will not resort to alcohol, because alcohol is very expensive in India, and if the father can come out of alcohol habit, that means a lot for the family. So that's how it is. Yeah. So thank you very much. So that's I'm done. I think there are some comments. Are there some comments?
Yes, sir. Actually, before that case presentation, one question was asked by Dr. Gargi, that question was like, sir, how to counsel the caregivers with a single child suffering from life-limiting illness, sir? How to counsel the caregivers with a single child suffering from life-limiting illness?
Yeah, exactly. That's an important question, because you need to, you cannot, it's not a single episode of counseling. You have to go on doing it stage by stage, because you have to first discuss the disease. You have to take examples and then say that this is how things might progress in the short term, not in the long term. So imagine it's a Duchenne muscular dystrophy. You cannot say that the child is going to die. You can say that this is going to progress, and after that, this is what we're going to expect. Then you have to put hypothetical situations. What will happen? Well, see, even if a child is now walking, your child is unable to walk after 2 years, it's still all right. It's still your child. So how will you take it? So then the parents will start vocalizing about it. They will vocalize more and more about having the child without the ability to walk. How will they receive it? Then counsel them on that. And then when they have reached that stage, take the next stage. So it goes on step by step. Of course, you need to counsel the caregivers, whether it's one child or two child with any life-limiting illness. Go by stages, and you should not push them hard. You go only by their own progress, by the way they understand, and then understand the situation, and then do not confront them at any cost. Never confront them. If they have a difference in discussing, they find it difficult to discuss something, leave it at that. But then put the options open. Make sure that they can come back to you for further discussions at any time. So that's how I would do it. Thank you.
Thank you, sir. Thank you very much for your valuable this one. And Dr. Gargi raised hand. Would you like to ask something, Gargi?
Sorry, my mistake. Thank you, sir. Thank you for clarification.
Thank you, Gargi. Okay, once again, I thank Nandakumar sir for this wonderful sessions and your sessions and comments on the case presentation also. So